Alrighty, welcome everybody to our sixth anatomy tutoring session. We've got some really great presentations lined up for you today, learning about respiratory system, anatomy, histology, and embryology. So all three should complement each other pretty well. As far as updates go, I don't have a lot. I just saw a lot of you last week. Nothing really major there other than I promise we're gonna get that histology atlas soon out. We've just been getting some final updates on our sources and making sure they're ones that we are allowed to use. Beyond that, after this session, we're gonna be into the new year. So if I forget to say at the end, then I hope everyone has a great holiday. So with that, I'll just turn things over to Dr. Frank to introduce our first speaker. He might be frozen today.
Oh, it looks like we might have lost him.
All righty. So our first speaker is, that should be Adam, correct?
Yeah, I think we're going
our anatomy. All right. So Adam Tickle is from Opelika, Alabama. So he's with me in Auburn now. He graduated from Auburn University and got a bachelor's in microbiology. He stayed in Auburn, Alabama because it's so great, and he's a second-year student at VCOM Auburn. Adam's first experience with anatomy was in high school dissecting frogs in Mrs. Gore's anatomy lab, and he's wanted to be a doctor ever since. When Adam's not studying anatomy, he's hanging out with his friends, doing jujitsu, or taking a well-earned nap. I would also need a nap after jujitsu and med school. Adam's favorite subject is anatomy, especially cardiopulmonary anatomy. So cardiopulmonary, no better speaker than for Adam to teach you the anatomy. So with that, I'll turn it over to him to start sharing his screen, and we'll give him 30 minutes or so to give us the rundown.
Hold on 1 second. Let me start sharing my screen. All right. Can everyone see my screen pretty well? Perfect. All right. So Dr. Scare introduced me. As I said, I'm Adam. I'm super excited to do this. I fell in love with anatomy in high school around the time when y'all are learning it, and so really excited to teach y'all. I guess hopefully get y'all as excited about anatomy as I got in high school. All right, so let's get this started. So we're learning about respiratory anatomy today. It's a good, as I understand, y'all learned about cardio anatomy last week, and respiratory anatomy is just a good follow-up off of it, just because it works so tightly with it. All right, so let's go on to the lecture objectives. And whenever you're doing a lecture, it's always just a good idea to go to review the things you need to take out of this lecture, the things that are really important. So the first thing is structure and function of the respiratory system, and that's all anatomy is, structure and function. So make sure you understand the basic structure of the lungs, the windpipe, all those sort of things that carry air in and out of our system, like the lungs and the trachea. Then to identify the structures at the hilum of the lung. Now, the hilum is how the lungs kind of connect to the windpipe area and the trachea and also into your heart. That all the blood and all the air that needs to get into the lungs flows through the hilum. That's why it's so important to understand it. And last is discuss the movements of respiration. So the lungs aren't a muscle. They're a big sack of air that needs to get filtered in and out. They don't have their own ability to move and breathe in and breathe out. So we have to help it. And that's where the diaphragm comes in. That's where all the muscles around our diaphragm as well that we'll learn about too. All right, now before we get going, does anyone have any questions about any of these lecture objectives or anything we're going to be learning today? All right, great. Let's go ahead and get this started. All right, so first off, I like to divide the respiratory system into two parts. So when you think about it, what I'd like to start with is everyone take a good deep breath in and breathe out. So when you think about that, a lot of things had to happen there all at once. Air had to go in through your mouth or your nose, and had to make it all the way down to your lungs. And then once it got there, it had to get filtered in and out. You had to take in the oxygen from the air, but you also had to put carbon dioxide back out into the air. So all that had to happen at once. And for that to work, there are two parts of your respiratory system. There's the conducting system. When you think of I keep saying the expression your windpipe, just because it's so good for describing what it does, is it carries the wind in and out of your nose and your mouth all the way to your lungs. You have that area in your nose and your mouth, all the way down to about your chest, and even part of the lungs is part of the conducting system. And then we have the respiratory system. That's where all the magic happens. That's where we exchange all the oxygen we just breathed in for CO2, and that's where we actually get the air for our body. And so the first thing I'd like to talk about is the conducting system. All right. So it all starts with the pharynx. Now, the pharynx is essentially, in general, a space in the back of our throat and the back of our mouth and our nose where all the air comes in that we breathe in. So if you breathe in through your nose, it enters the nasopharynx. Nose, nasal, that adds up. Nasopharynx in the back of your nose. And then your mouth, it enters the oropharynx in the back of your mouth. Oropharynx adds up too. And then they all meet together. I don't know if you can see that purple section into the laryngopharynx, which is the area where all the pharynx adds up into one section and it sits above your voice box, aka the larynx. That's why it's called the laryngopharynx. Right? And also one thing that's important about this structure is that it's covered in mucus-producing epithelium. So whenever you think of like snot or just saliva or anything like that, you have mucus coming out of the epithelium and then your pharynx. The reason that it's important is that when you're breathing in all sorts of dust and particulates, and that needs to get caught and needs to get pushed back. So that's what that mucus can do. It can catch dust particles and stuff like that and protect your lungs. Also, it helps warm up the air. Seems like a silly thing, but if you breathe in really cold air, sometimes it can make it hard for your lungs to process it in and out. You like warm, you like to have it humid. That's where your lungs work best, is warm, humid air with very little dust in it. All right, let's move on to the next portion of the conducting zone, the larynx. Now, larynx just sits just below the laryngopharynx, and it's called your Adam's apple. So if you ever feel, I'd say let's all try this. It's our throat. You feel that hard cartilage piece right there? That's your larynx, or the front of your larynx. It forms this kind of shield on the front of your throat. It's this big cartilaginous, I said shield. And what it does, it has two really important functions. First off, is it holds your vocal cords, things that make your voice. So there are these two fibrous pieces that sit in your larynx. This diagram doesn't do a great job showing them, but they sit in your larynx, and that's what vibrates to make the sound of your voice. And you have muscles in there that can adjust them in order to allow you to produce different volumes and different tones of sound. So that's how you make your voice. That's also what's called your voice box, because that's how you make your voice right there. And another thing it has is, I don't know if you can see at the top of the diagram, is something called the epiglottis. Now, the epiglottis is like a trash can lid. You know, when you put your foot on the little pedal and it pops up like a trash can lid, that's exactly how it works. The reason why you need that is that your larynx sits just in front of your esophagus, which is where you get all your food through. You swallow something, it has to go down your esophagus, so all your food comes in. And both the larynx and the esophagus connect to your mouth. But you don't want food going down into your lungs. That'd be really bad. You could get pneumonia through that. All of y'all have had the experience of something going down the wrong pipe. We don't want that. So we need to have a system in order to direct food and air to where it needs to go. So when you're swallowing something like swallowing food or swallowing liquid, epiglottis shuts like the trash can lid, and anything goes into your mouth goes into your esophagus behind the larynx. But when you're breathing in, epiglottis opens, air can flow into your larynx and allows you to breathe. All right, also, the next slide we're going to go into is we're going to look at some photos of some real, some cadaveric images. I'm sure y'all have seen a few of those before, but what that means is that we're going to look at some images of people who have donated their body to science in order for us to learn. I think it's a very important thing to look at. Let's give the best image of anatomy. However, it can be a little jarring if it's your first time seeing it. So is everyone ready with that before we move on? If anyone has any problems, just let us know. We're good? All right, on to the next slides. All right. So the first thing, if you look on our left, it looks kind of like that diagram we showed earlier, showing the nasopharynx and the oropharynx. You can kind of see, can y'all see my cursor? It's not letting me show my cursor, hold on. But if we look at the left, you can see that little blue circle. That's the start of the nasopharynx. Air flows into the back of our nose there, and it can join down and flow downward until it meets the back of our tongue, or the oropharynx, and then they join together to form even kind of just below the tongue and to the laryngopharynx. Now, if we also look to the right on this photo, that's a photo of the laryngopharynx, but looking from the back side of it. The reason why that's important is that just behind the laryngopharynx, you see the entrance to the esophagus. You see how they just kind of jut up right next to each other? That's a really important thing to understand, is as I was mentioning earlier, is we need to have a system in order to direct where food and where air goes. That's why I have the epiglottis fold right there. Now, if you look just above the epiglottis, you see that little, I guess, kind of squiggled thing. That's actually the base of your tongue. So the epiglottis lines up right next to the base of your tongue right there. And above that is your uvula, the little dangly bit in the back of your throat. See how it all kind of adds up together? The epiglottis opens up to allow things into the larynx, but it closes down, pushes things behind it into the esophagus. All right. Now that we've learned a little about that, let's talk about what's next. So just below the larynx is the trachea. The trachea can be best described as a stack of C-shaped rings. So just below the trachea, you have these cartilaginous rings that stack up onto each other and go all the way down into your chest. And behind these C-shaped rings is a little bit of a muscle. And this system forms a tube that connects the air from your larynx all the way down into your bronchuses. Now, I didn't mention this when we were on the larynx, but I think it's an important thing to talk about, is that in your mouth, in the nasopharynx and the oropharynx, laryngopharynx, we had mucus-producing epithelium. We'll have some mucus-producing epithelium here too, but we also have something called pseudostratified ciliated epithelium. Now, we'll learn a little bit more about that when we get to the histology slide, but it's important to understand here is that pseudostratified ciliated epithelium acts like a brush or a conveyor belt. So if something gets past our nasopharynx and all that system up here, it doesn't get caught. We need to have a system to move all that dust back up. So it lands on the pseudostratified ciliated epithelium, and those cilia on the epithelium kind of, as I said, work as a conveyor belt, moving stuff up, hopefully back into our throats or our mouth. We can swallow it or spit it out or cough it up. Otherwise, it would just stay there. So as I said, it looks like a conveyor belt kind of cleaning the lungs and the trachea. All right, next portion is the bronchi. Now, once the trachea gets down kind of behind the chest, well, into the middle of the chest, about, I think, T5, the level of your thoracic spine, level 5, it splits off into your bronchi. Now, your bronchi divide a bunch, but it's important to understand when and where they divide and what they go into. Now, the first division is they split at something called the carina, which is just a fancy word to say where they split. They split it into two parts, your left and your right main bronchi or primary bronchi. You have a left and a right lung, you need a left and right primary bronchi. Now we're going to divide again because each lung has individual lobes. Your right lung has 3 lobes, your left lung has 2 lobes. So we're going to divide one more time into lobar bronchi or secondary bronchi. Then each lobe then has segments inside of it. Now each segment needs its own bronchi, and so then they're going to be called segmental bronchi or tertiary bronchi. Then off the tertiary bronchi, we have bronchioles. Those are the really small portions, and that's actually, I think it's important to understand about the bronchioles, is that they're the first portion that doesn't have cartilage around it. They're going to be mostly smooth muscle. The reason that's important is that bronchioles, whenever you need more air, let's say you're exercising, you need to breathe in a lot more, the bronchioles will expand. Your sympathetic nervous system will kick in and tell your bronchioles to expand and breathe in more air. It's a really cool system that allows you to just take in more and more air than you would need at rest. This is also something that can be taken advantage of if you know someone with asthma or something like that, or a condition like that, they might not be able to take in as much air because of mucus blocking the windpipe or something like that. What we can do is we can take a sympathetic agent like epinephrine or something that you can breathe in, like an inhaler. And what that'll do is it'll go into the bronchioles and tell them to expand. Because the mucus was blocking up the windpipe, blocking up the bronchioles before, but that sympathetic agent tells the bronchioles to expand, bring in more air. It's not a lecture objective, but I just want to go over that because I think it's a really cool way, and that anatomy crosses over with how, if you understand anatomy and form and function, you can use that and manipulate that, help take care of people. All right, now that we've gotten to the bronchioles, that's the end of the conducting zone. That's the end of the area where it's just moving air. Now we're going to get to the area where it's actually moving air into the blood and out of the blood. So we're into the respiratory zone. The respiratory zone, the primary function of the respiratory zone, as I've said, is to move the air in and out. And that's done at the alveolar sacs. So the bronchioles end in something called respiratory bronchioles, which hold alveolar ducts, which is like a cluster of grapes or a cluster of alveolar sacs. Then these individual alveolar sacs is where the air flows into at the very end. Now these alveolar sacs are really, really thin, like imagine like a grocery bag. They're exactly like a plastic grocery bag. They're really, really thin and floppy, but because they're so thin and floppy, they're perfect for moving air in and out. The air hits the grocery bag, it can push out. There's little holes in the grocery bag, it can push out, or the carbon dioxide in the blood can push the opposite direction. They're perfect for being permeable and allowing stuff in and out. So the way it works is that deoxygenated blood from the rest of your body comes up into the lungs and wraps around the alveolar sacs, alveolar ducts, and carbon dioxide enters the little alveolar sacs and oxygen leaves back into the blood. And then that deoxygenated blood becomes oxygenated, leaves the lungs, and is pumped out into the rest of your body. I was a little bit of, I guess I talked a lot for that one slide, and there's a lot of stuff that happens all at once there. Does anyone have any questions about this one slide or anything I just mentioned? All right, and we'll have some more question time at the end. So if there's something you don't want to ask now or something comes up, don't be afraid to stop me or bring it up at the end. All right, now that we mentioned all of that, it's good to talk about the actual lungs themselves, the actual shape and structure of the lungs. Now, as I mentioned, you have two lungs, one on each side of the chest, and that's where all that gas exchange happens. So the right lung has 3 lobes, and the left lung has 2. The right has a superior, middle, and inferior. The left lung has a superior and an inferior lobe. It doesn't have a middle lobe. Now, each one of those lobes has individual segments. As we mentioned, they each have segmental bronchi and have individual segments. The reason that's important is because each one of those segments has, like I mentioned, has its own unique bronchi and also has a unique blood supply. So if you were ever to develop lung cancer, it'd be important to know the segments in order to remove individual pieces off, because a lot of times it doesn't cross over at first. Now, the segments, there are dozens of them. You don't need to memorize them yet, but it's just a good thing to be aware of that they have those segments. Also, this is something that would be hard to tell off this image, but well, this image shows it just a little bit. If you were to say, if a kid were to say to swallow a battery and it went down the wrong pipe, if you had to guess, where do you think, just looking at this image, where do you think that might end up? There are no wrong guesses here.
No, probably like between where the trachea splits, the bronchus.
That's actually a really good, so for a battery that's a little bit bigger, it would fall somewhere, but for small particles love to get stuck right there. So that's actually a really good point. A lot of times we could develop cancers, especially smokers will develop cancers right at that split, at the carina. But for bigger things, they actually are going to keep falling down into the right inferior lobe. If you can look at that diagram on the right side, see how it forms that long straight path, almost kind of continuous with the trachea, just a little bit deviated? That's where a lot of things, a lot of like batteries or small objects like to get stuck. But for small particles, as you were right, it's dead on the money, is that they love to get stuck at the carina, and that's where people there are a lot of cancers there, a lot of bad stuff happens there. That's a good point. Does anyone have any questions about that? All right, we'll keep going then. All right, now here's a good image of the lungs, of some real lungs. If you look on the left, we see the picture of just the different lobes. Now you see on the right side, it has the 3 lobes. It is a superior, an inferior, and a middle lobe. But if we look on the left, it just has that one split because it just has 2 lobes. Now, if you look on the right side of your screen, I included this one because it's good to see how it's all kind of scrunched up in there. A lot of times it's hard to visualize that, but the lungs have to wrap around the heart. I like this picture because it shows just how much they kind of have to mesh together. We'll learn a little bit more about that when we talk about the hilum, but how the lungs kind of sit wrapping around the heart. All right, now that we talked a little bit about about the lungs themselves, let's talk about the pleura. Now, you learned about the heart last time you were here, and the heart had something called pericardium on it. So the sort of fibrous layer that wraps the heart, lubricates it, and it kind of protects it from the outside. Your lungs have the same thing. Your lungs have to move a bunch when you breathe in and out. So it needs something to lubricate it, help it move. And that's why it has something called pleura. Pleura is, like I said, that fibrous layer that sits outside the lungs. There's an outer layer that sits kind of on your rib cage and your intercostal muscles. That's your parietal pleura. There's an inner layer called the visceral pleura, which hugs the lungs and really tightly. And in between them, you're going to have pleural fluid inside the pleural cavity, and your lungs move in and out inside that space right there. Can you all see the diagram I included? It's, hold on. Oh, cool. All right, now, as I mentioned earlier, we're going to talk a little bit about how the vessels get to the lungs and get out of the lungs as well. So the way the lungs work is they need to receive deoxygenated blood, and they get that through the pulmonary arteries. So the way that works is blood flows into your heart, And then the heart pumps it right back out into the lungs, so the pulmonary arteries from the left, not the left, the right ventricle. The right ventricle pumps blood through the pulmonary arteries into the lungs. The lungs exchange CO2, it pumps out the CO2 and sucks in all the oxygen. And then your heart sucks all that blood back in through the pulmonary veins and then pumps it out through the left ventricle. Now, another thing that enters the lungs, as you mentioned, is the bronchi. So there's a lot of stuff going in and out of the lungs. And so it's important to understand the anatomy of that for just so you know, like if you were to see a lung, or if you're one day you want to do a surgery or something and you see a lung, you need to know how it's all getting in there. And one thing that's important is understanding where the pulmonary arteries are. And the way I like to do that is through the mnemonic RALs. I believe Dr. Prescura taught me this one. We go on to the next slide, and we'll talk a little bit more about that. All right, so if you look at the lung on, I guess it's on your left, but it's the right lung. You can see in the bottom corner, it's the right lung. And we see the bronchi, right? So now we need to find the pulmonary arteries. Pretend the label isn't there. We need to find the pulmonary arteries. Well, to do that, I use like the mnemonic RALs. So it's a right lung. The A stands for anterior. So anterior to the bronchi is where we find our pulmonary arteries. Straightforward enough. As you can see, the label, the pulmonary arteries sit right in front of the bronchi. The pulmonary veins are a little bit more anomalous in the sense that they kind of do their own thing for the most part. But if you can find your pulmonary arteries, then you can rule out where the pulmonary veins are. Like, oh, we have found my arteries, got my bronchi, these must be our pulmonary veins. And now we move on to our left side, we see our bronchus, all right? So it's RAL, so let LS. So it's a left side superior. You go just superior to the bronchus and you find your pulmonary artery. And that's how you find that. If you're given a lung, you need to find a lot. It's a very common thing. I'm pretty sure Dr. Prescura has labeled this for me before, is you'll get a lung and you'll put a pin on some portion of the hilum and you'll have to figure out, what is this? Is this a bronchi? Is this a pulmonary artery? It's a pulmonary vein. You need to be able to figure that out quickly, and that's why you use RALs. All right, now that we talked a little bit about the anatomy of the heart, I'd like to talk about what makes all this air move in and out. Because as I mentioned before, the lungs aren't muscles. They can't just suck air in and push it out on their own. They need a lot of help. So the way that works is for inspiration or breathing in, what we do is we need to create space in our lungs. We need to decrease the pressure, and we do that by creating space, like opening up a big vacuum. So what we can do is our diaphragm contracts, which causes it to lower down. And then our chest goes up. Our ribs go up. And this sort of creates that big space for air to rush in. So air rushes into our lungs as we lower the pressure and increase the space, encouraging all that air to go in. And then on the opposite side of things, we need to get all that air out once we're done with it. We have put all the CO2 in the air. We don't want it anymore. We need to get it out. So we can do that by doing the exact opposite. So our diaphragm will relax, which causes it to lift up. Our chest sinks lower, and so that decreases all the space, which kind of squeezes the lungs like a sponge. So all that air was like water, our lungs were like a sponge, and we just pushed it all out all at once. Send it the exact opposite direction. Now, as I mentioned, diaphragm, there's a bunch of actual other muscles that contribute a lot to this. So especially whenever we're exercising or when we're consciously breathing. I don't know if y'all have noticed, when you're sitting around breathing, you don't think about it at all. But all of a sudden, when you think about breathing, or someone says, take a deep breath, as I did earlier, you really consciously lift up your chest. You actually start using all those extra muscles, you know? And so that's when these things kick in. So for taking good, deep inspiration or breathing in really hard, we need to lift up our chest. And we do that with our neck muscles, which are our sternocleidomastoid, which is right here, and our scalenes, which sit on the side of our neck. And we also use our external intercostal muscles, which are connected between our ribs. All that together lifts up our chest and creates a bunch of space with the diaphragm going down, bringing all that air in. And then if we need to breathe out, we need to collapse our chest. We need to bring everything down on the opposite direction. And we can do that with our internal intercostals, which go the opposite direction, as well as using our abs. You know, if you ever breathe it out really hard or try to play an instrument, you kind of curl forward a little bit. Your abs kind of kick in and your back kicks in as well. All that lowering your chest down really quickly, your diaphragm going up, squeezing the sponge, pushing all that air out. All right. And here are some of our references. And yeah, do any of y'all have any questions about any of that? And we went through a whole bunch. Like it's it's hard to cover all the respiratory anatomy in 30 minutes, but if y'all have any questions, so if y'all have any questions about that, something I went over too fast or something you're curious about, let me know. Yes, let's see.
So first, I'll just say, Adam, excellent presentation. That was so awesome. I really appreciate you asking questions throughout and, kind of getting them involved through the process. That was awesome. So first question from Sethwika, if you want to unmute or type in the chat, whatever you prefer.
Yeah, so I had a question about CPAP, continuous positive pressure, like the airway device for sleep apnea. I was just wondering how that worked in terms of the pulmonary system.
Gosh, I'll admit I haven't reviewed CPAP recently, so I'm not, so just take whatever I say with a grain of salt. And so a lot of times in med school, you try to retain as much as you can, but just bear with me. So CPAP, as I understand, a lot of times the reason people use it for sleep apnea is they develop something called obstructive sleep apnea, which is for some reason, some portion of the back of your throat kind of gets a little bit larger or something in your throat kind of obstructs. And so the reason people use CPAP is you need to have that positive pressure. The word in CPAP is positive pressure. And so it's trying to push air past whatever that obstruction is to make it easier to breathe, is that you can't generate enough force to pull all of that air in. So you use CPAP to push it in really fast. It's a lot of times people use, a lot of times what reason people are intubated as well, to push air into the lungs. I'll have to look up into it to find a little bit more information. That's as I understand it, that's why people use it for sleep apnea, is to push past whatever that obstruction is.
Oh, okay, got you. Thank you.
No problem.
I can just add that CPAP means continuous positive airway pressure. So by putting positive airway through the nasal and even oral cavity, is you are going to prevent the soft palate from closing off the airway. And by doing so, that's kind of like an air splint, and keeping the airway opens and allowing for normal respiration. Otherwise, you get these events called apneic events where you basically stop breathing, and you could have multiple over a very short period of time, and that will obviously disrupt sleep. So,
Got you. Thank you.
and I hopefully am back for good here. So we had a question about the epiglottis, and do we control it consciously or involuntary, and its action when we swallow? Does it close automatically?
So it closes, as far as I understand, there's no conscious control of the epiglottis. The only kind of thing we have close to conscious control is that you can consciously swallow. And so when you swallow, your epiglottis shuts like that trash can lid to allow stuff in, and then it opens up all of a sudden when you're breathing. So we don't really have any conscious control of the epiglottis, except, as I said, swallowing. That's how you can force it to shut. Another interesting thing about the epiglottis is that, I guess this certainly isn't conscious control, but whenever you hear someone being intubated, like if they're at the hospital and they need to have a good airway, one thing you have to do is need to lift up the epiglottis. It's sitting in that kind of closed position, or at least kind of obstructing the path towards the respiratory system. You insert, a device that kind of lifts up the tongue. And when you lift up the tongue, it pulls the epiglottis out of the way and allows you to push some sort of breathing tube into someone's trachea, into the larynx. So that's one way you can manipulate the epiglottis. But as far as I understand, you can't consciously control it outside of swallowing.
Sure, many of you have felt your epiglottis fail a time or two, and you kind of choke on something a little bit. So it is an involuntary thing that occurs as part of swallowing, but it is something that it's involuntary, but it's not perfect. So next time you guys choke on something on accident for a minute, you can say, "Oh, I'm sorry, my epiglottis failed," and sound super smart when you're saying that.
I see the next question is, when a patient is intubated, it goes down through epiglottis, trachea, and larynx, right? So how does everything stay intact? What happens if something rips? Now, gosh, that would have to be, I guess it's something that does happen. I don't know the specific management about how if something rips. Generally, it's considered a safe procedure. You know, a lot of times surgery is not common. People are intubated all the time. A lot of times, whenever someone's in the ICU, they're going to intubate them just to go maintain their airway. So it's generally a relatively safe. Those are, as I mentioned, those are tough structures. The trachea is like cartilaginous rings. It's relatively strong. Everything in your larynx is relatively tough too, and your epiglottis is also relatively tough. So you're generally not going to tear things up moving through it. However, I imagine that has happened before. I wouldn't know anything about the management of those complications. I imagine you would certainly remove and try to have someone go in and do surgery and repair. But I don't think it's that common. I think those things are relatively tough. That's a good thought, but I just don't think it's super common as far as I know. People saying their lung. All right. So when people say your lung collapses, are they talking about specific chambers or the entire right or left lung? So the way a lung collapses is that your pleural cavity has to maintain a certain amount of pressure. And so if something were to disturb that pressure and the pressure were to all of a sudden increase, your lung would kind of, in general, all of a sudden collapse. It equalizes with the outside pressure and allows your lungs to lift up and it kind of crushes down because it has to have maintain its own normal pressure. As we talked about earlier, breathing in and out is done by changing the pressure inside and out of your lung. So if you all of a sudden equalize the pressure inside the pleura with air around it, it would cause an issue. Now, in terms of is it the whole lung or is it specific chambers? As far as I understand, it's the full lung in and of itself. I don't haven't heard of a specific lobe singularly collapsing. I think it's just the whole lung. If Dr. Frank and Dr. Brisker would know more about that, I think it's just the full lung collapsing.
I think there can be things like a partial lung collapse depending on the type of injury, but beyond me just knowing that that can happen, that's kind of the extent that I could comment on that, unfortunately. I don't know if Dr. Peterson or Dr. Frank have any better insight to that.
I would just add that there is a term called atelectasis, and that is the collapse of lung, whether it be the entire lung or a part of the lung known as lobe. So yes, you can have a lobar collapse or you can have the entire lobe collapse, and you would be able to hopefully see that on x-ray, chest x-ray. So yes, it is possible to have a full lung collapse or partial lung collapse.
Interestingly enough, I actually I was shadowing a doctor last week and I saw a patient with a lung collapse. It was the most interesting thing is that you see a lot of x-rays whenever someone's showing it in a PowerPoint, but actually seeing a patient's with their lung was you see all that not dead space, but air, and then their lung is shifted all the way up. And since someone mentioned it, I'll talk a little bit about the treatment is that you treat with a chest tube, or one of the ways you can treat is with a chest tube to alleviate that extra pressure. It was interesting. I saw the doctor put in the chest tube, and then we went back downstairs. We talked for like 20 minutes, and then he pulled up the X-ray, and her lung was already mostly back to normal. So that's something that's really interesting. That's a good question. Thank you for asking, Ryan.
Yes, we've had very good questions. Thank you very much. Anything else for Adam before we let him go? Job well done. And thank you so much. And so you'll be seeing Adam again. So looking forward to it. So Adam, you can quit sharing, and we're going to move on to our second presenter. You all know her, Emmeline Whitwer. She's going to be speaking about the histology of the respiratory system. And if you forgot, I will remind you that Emmeline is from Washington State. She's a graduate of Rhodes College and is a current medical student at Drexel University. She aspires to become a radiologist. In her free time, Emmeline enjoys hiking, playing pickleball and tennis, and hanging out with her cat, Leo. Her favorite body system is the cardiovascular system. So I will hand this over to you, Emmeline, and you can present on the histology of the respiratory system.
Great. Okay, I think you all should be able to hear me. And can you see my cursor? Because I know Adam was not able to have people see that. Can you see mine?
Yeah, I can see both.
Okay, perfect. Okay, great. All right, so yes, this will be histology, so it'll go nicely off of what Adam was talking about. We'll get into the cilia, and he was talking about the elevator of cilia moving things out of the trachea, so we'll get into what all of that looks like on histology. So we have these lecture objectives, and we'll just take a moment and go through them and kind of orient ourselves to what we're doing. So we will be identifying and describing the 4 layers of large conducting airways. That is the mucosa, submucosa, hyaline cartilage rings, and the adventitia of the trachea and bronchi, including their morphology, location, and function. We will identify and describe the histological organization of the 3 types of bronchioles, which are the conducting bronchiole, terminal bronchioles, and respiratory bronchioles, including their morphology, location, and function. And then we will identify and describe the histological organization of the respiratory zone, the area that's actually able to do gas exchange, and that is the alveolar ducts and sacs, including their cellular components, morphology, location, and function. And lastly, we will identify and describe the different cell types within the respiratory zone, namely the type 1 alveolar cells, type 2 alveolar cells, and the macrophages, and their morphology, location, and function. So Adam went over this. There is a conducting portion, which is separate from the respiratory portion. So the conducting portion, just to reiterate, is involved in the movement of gas in and out of the lungs. It does not participate in gas exchange. And basically, it ends as soon as you start to have alveoli that are able to do gas exchange. And we'll get into where exactly that happens in the lung. And on the image to the right, the trachea, the primary bronchi, and the secondary bronchi that you can see here labeled would all be considered part of the conducting airway. They are not participating in gas exchange. They are just moving air into the lungs and out of the lungs. So we'll get into the mucosa of the large conducting airways, and then we'll go over the submucosa and the hyaline cartilage and the adventitia. So this is just the mucosa. It is a respiratory epithelium with pseudostratified columnar cells that have cilia. And as Adam was talking about, that elevator of movement out of the lungs and out into the trachea and then out where you can cough it up is through the cilia. So you can see them right here, and we'll get a better view of them, or closer view of them later, but they have this beating motion, so they can move debris, which is really cool. And you'll also see occasional goblet cells, and they create mucus. So you'll have mucus out here created by the goblet cells, and the cilia can move debris in the mucus up and out. You can see a thick basement membrane here, and then, oops, I accidentally clicked going back. Okay, so then below the basement membrane is a lamina propria, and all of those layers is the mucosa. So the cilia, the pseudostratified cells here, the pseudostratified columnar specifically cells, the basement membrane, and then the lamina propria is all of the mucosa. And then below that is the submucosa, and it is separated from the mucosa by a layer of elastic fibers. They're hard to appreciate here, but there are elastic fibers that separate the mucosa from the submucosa. And the submucosa has glands and lymphoid tissue and those play an important part in protecting against inhaled pathogens. So we're just diving deeper into the epithelium and into the tissue that makes up the trachea. So out here is the lumen of the trachea. Then we are going into the mucosa, which I explained on the first slide. And then down here is the submucosa. And next we'll talk about the hyaline cartilage, which is right down here. And that is type 2 collagen because it's hyaline cartilage. All hyaline cartilage is type 2 collagen. And it is making up those cartilage C-shaped rings that are in the trachea. And oops, we'll go to that slide in just a second, but they are open in the back. So in the posterior, here is an anterior view, but posterior to the trachea is the esophagus, and where the trachea is right next to the esophagus is where those C-shaped cartilage rings are open. As you get farther down into the bronchi and secondary bronchi, the cartilage rings are no longer C-shaped. They are more circular. And then as you get even smaller and smaller, the cartilage becomes irregular, small plates. And we will see that in a better image soon. But just know that in the trachea, the cartilage is C-shaped. Then as you get farther and farther down, the cartilage becomes more sparse and it's no longer in a C-shaped ring. So here is a cross-section through the trachea. So here is trachea, lung. If we were to cut right here where this blue arrow is and just open that up, we would see this. And this is the trachea. And then back here is the esophagus. So this would be posterior. This is anterior. So just kind of orient yourself to that. Remember the C-shaped rings we were talking about? That is what you're seeing here. This is a cartilage ring in the trachea in a cross-section image where you can see the esophagus sitting behind. And that all lines up with what we were saying with how the open part of the C-shaped cartilage ring is where the esophagus is. And there's actually a small little muscle called the trachealis muscle, and it connects the C-shaped rings of the trachea. And then if you look at this red box and then look over here, this is just a blown up image of that. So you can see and appreciate the fact that the hyaline cartilage looks different from the surrounding tissue. And then there's an adventitia that is farther outside from the cartilage. It is loose connective tissue, and it sort of like webs the trachea to the adjacent structures. And it contains blood vessels and lymphatics. So we've just been moving farther and farther out as we have been talking from this epithelium in here to the cartilage rings, and now all the way on the very outside is the adventitia, and that is what connects the trachea to the surrounding structures in that area of the body. Okay, so now moving on, the bronchi, they still have the respiratory epithelium, and that is that pseudostratified ciliated epithelium. And here is a better image of that cilia. You can actually see these little cilia that are able to do that beating motion to move debris up and out of the airway. There is a goblet cell here. Remember, I said that the goblet cells are important for creating the mucus that the cilia is then able to beat up and out. So it's the goblet cells specifically that make that. And so now the cartilage, when you're here, is in rings instead of that C-shaped that you would see up here in the trachea. And then the even smaller bronchi will have the irregular plates of cartilage. Here you can see a bronchi cut in cross section, and down here I think it's a little easier to appreciate. This is the same image. Down here it just different. This one is stained, so I think it's a little easier to see here that the hyaline cartilage is much more sparse. You see it here, you see it here. It's not a full C-shaped ring or even just a ring around the bronchi. It's just small little irregular plates of cartilage. And then I think it's also cool to appreciate that the bronchi are very large when compared to the alveolar sacs that you see out here, that those areas are able to do gas exchange. The bronchi are very large. They are just conducting air in and out of the lung. Then we get into the bronchioles. After the bronchi, there's the bronchioles, there's conducting bronchioles, terminal bronchioles, and then respiratory bronchioles. And it's important to note that the respiratory bronchiole is the first place that gas exchange occurs. So as we've been moving down, no gas exchange has been occurring, but once we get to the respiratory bronchiole, that is where we are first having gas exchange. And that name makes sense. The conducting bronchiole is the first bronchiole that you get to, then the terminal is the last place where you don't have any gas exchange. That's why it's called the terminal bronchiole, and that leads into the respiratory bronchiole. So that is the distalmost, and we'll go through what these three look like. So starting with the conducting bronchiole, remember that was the first one, then it goes to terminal, and then it goes to respiratory. So this is the first bronchiole. It is conducting bronchiole, and you will see bronchiolar epithelium, and that still has some ciliated cells, but you'll also see what are called club cells, and they look like this. They stick out a bit. So that's like why they're noticeable. And then the cilia you can still see are there, but becoming more sparse. As the bronchiole gets smaller and smaller, the number of ciliated cells will decrease, the number of club cells will increase, and then the number of those goblet cells that we had will decrease. The function is to conduct gas and move debris with the cilia. And then these club cells, they contribute to the products that make up surfactant. Surfactant is a cellular product that decreases surface tension on alveoli to make it easier for them to stay open. So club cells, they're making some of the protein for surfactant, but they don't make everything that is in surfactant. These club cells, they also degrade toxins, and they serve as stem cells for this bronchiolar epithelium. Terminal bronchioles are the smallest conducting bronchiole with a continuous mucosa. You can see here a terminal bronchiole, and we see all this mucosa is continuous. We're not seeing any breaking up into alveolar ducts yet. And it is the last portion, as we said, that does not participate in gas exchange. That's because there's no alveoli. All you have is that bronchiolar epithelium. All right, so then we get to the respiratory bronchiole. And they have a similar structure to the terminal bronchioles, but they have occasional alveoli, meaning that this is the first part of the respiratory tract that is able to do gas exchange, because alveoli are where that gas exchange is occurring, and we'll go into more detail of what that looks like in a few slides. And here it's notable that the mucosa is now discontinuous. So here in the terminal bronchiole, it was continuous, and here in the respiratory bronchiole, it's discontinuous, and you start having these alveolar ducts. So as you can see in this image, the respiratory bronchiole leads into alveolar ducts, and then alveolar ducts lead into many alveolar sacs. So here is another image where you would have, this would be terminal bronchial because it's all continuous. Then you would have a short area here that would be respiratory bronchial leading into the alveolar ducts that lead to many alveolar sacs. And an alveolar sac you can think of as like a bunch of grapes. So like a you know, at the store where you get just like a bunch of grapes, they're all like attached to their stems. And each grape would be analogous to an alveoli. And the bunch of grapes would be analogous to the sac. So each sac has many alveoli in it, and each alveolar duct leads to many alveolar sacs. I think that's like sort of a confusing concept because here we're just seeing it in a flat plane, but you could maybe see here, this could potentially be a sac right here of many alveoli. Over here, this could be a sac of many alveoli. Just think of it as like a bunch of grapes, and each grape is a single alveolus. Sacs are separated from each other. So like the bunch of grapes, they are separated from each other by an alveolar septum that is made of connective tissue and capillaries. And the septum between the sacs have pores that allow for pressure equalization. Here is another image where this could be a sac, and there are alveoli. You have to like realize that we're seeing it in one singular plane, but you could see if you had like the bunch of grapes and you just sliced through it, you wouldn't see all of the grapes, but you would just see in one plane some of the grapes cut in half, and that would be like here we can see some of these alveoli cut in half. There are like images on Google, but I think that they can be a little misleading because they'll show a bronchiole leading into a sac, and that's just not, you have to go from the bronchi, then to the 3 types of bronchioles, down to the ducts, and then to the sacs. So I think it's best to try to figure it out in this image. Like here, this could also be a sac of many alveoli, where we've cut those grapes in cross section and we can see sections of some of the grapes. Down to the actual alveoli, these are alveoli, these circles here. You have different types of cells. There's type 1 and type 2 pneumocytes, and they serve separate functions. So first we'll go over the type 1 pneumocytes. Here we can see some type 1 pneumocytes. They're very thin, very flat squamous cells, and they're important because across the pneumocyte, the type 1 pneumocyte, is where you have gas exchange. So gas exchange is occurring across these very thin, flat cells. They account for 40% of the cells of the alveolar epithelium, but they cover 95% of the surface area because they are so stretched out and thin, because they have to be super thin for that gas exchange to occur across them. And the lifespan for a type 1 pneumocyte is 3 weeks. The type 2 pneumocytes, they are more cuboidal, so they won't look as flat. You can see some of them here if you look at my cursor. They make up only about 5% of the surface area, and they are the stem cells of the alveolar septum that can differentiate into those type 1 pneumocytes. Because remember, we said that the type 1 pneumocytes only live for about 3 weeks. They synthesize the proteins and the lipid needed for surfactant. And remember, we said surfactant is a sort of liquid. It's a fatty liquid that decreases surface tension so that the alveoli don't collapse. They have phospholipids in them with a polar hydrophilic head and a tail that is hydrophobic, and they push water molecules apart, and that helps create a lower surface tension so that the alveoli don't collapse. So these type 2 pneumocytes are able to synthesize both the protein and the lipid needed for surfactant. Remember that the club cells were only making the protein for surfactant. So these type 2 pneumocytes are really important. Then lastly, there are alveolar macrophages in there, and macrophages are what eat up debris and then get debris out of the lungs. They can be found in the interalveolar septum and on the alveolar surface. Once they eat up the debris, they then move up the airway into the pharynx and then it out so they can be swallowed or coughed out. And here's a picture of just an individual macrophage. They have this is the nucleus here, this purple, and it's sort of irregular shaped. And then they have granules and vacuoles, and they go around and they just chomp up the debris so that it can leave. And here you can see these arrows are pointing to where some of those macrophages are. And that's it for me. And I'll do questions now.
I just want to say great presentation. That was really helpful. As always, I appreciate you breaking down these complex things and making them nice and bite-sized for all of us.
Yeah, my pleasure. Thank you.
And maybe, Emmeline, I think towards the beginning of your PowerPoint, you had a cartoon, and maybe it was in Adams and I'm misremembering this, but I think if you can either go to the beginning of your PowerPoint, I think it's difficult to get a sense of how gas is being exchanged across the alveoli until you see that picture that shows the alveoli with the capillaries kind of on the top of them, knowing that that's in the septum. So was there one that you had? Or maybe you can just point out again where those capillaries would be and remind the students that capillaries allow red blood cells to move through them one at a time. So it slows the movement of those red blood cells way down. And that's what allows the carbon dioxide to be exchanged for the oxygen.
Trying to think if you'd be able to see.
It looks
not-
like at the bottom of the line drawing that there might be a small capillary to the left and then maybe a smaller capillary over to the right. And that, I think that would,
Oh, could this be one?
yeah, exactly.
That could be one. Oh, here on this. Yeah, that could be the vascular epithelium here. Because you have to have that blood moving all in this area in these capillaries so that the gas, the carbon dioxide that's in the blood, you would want to leave, and the oxygen that's in the alveoli you would want to go into the blood. And that is happening. It's the red blood cells are carrying the oxygen and the CO2. And so you have one single red blood cell moving, and it's releasing the CO2 and picking up the oxygen
That was a great
as
job.
it passes through this endothelium right here. That is a very important concept that should be explained when talking about alveoli. Yes, you have It's all very, very, very vascular in here so that you can have those red blood cells dropping off CO2 and picking up oxygen. Thank you. Thank you for pointing that out, Dr. Peterson.
Okay, we had a question from Sahasra. Why do cartilaginous rings need to be C-shaped in the trachea?
Okay,
I think is an excellent question.
here we go. Okay, so here in the trachea, we have these C-shaped rings, and in between the C is a muscle called the trachealis, and it's there so that when a bolus of food is moving down the esophagus, the C-shaped ring will have some give. You need that bolus of food to come down and have space, and basically, yeah, have some give so that it's not just brushing up against something that's really hard and can't move. It all has to be like flexible with each other. So you wouldn't want this to just be one hard full circle ring of cartilage. You have to have this space here with the trachealis muscle in between so that the bolus of food can move through. Also, if you need to like make the space you have like a little bit of give for tightening the airway, a tiny bit. Let me know if that answers your question, or if you need any other clarification on that.
Okay, are there any other questions for Emmeline? I'm not seeing any. So if there are none, we can move on to our next presenter. Emmeline, once again, thank you very much for your presentation. Another excellent presentation. So with that, I will introduce our third presenter. She is new to the group, but will become a familiar face soon. Her name is Marla Jo Lindsay, and she is going to be discussing the embryology of the respiratory system. So Marla is from Alabama, and graduated from Auburn University with her bachelor's in biomedical science. She is currently a second year at Edward Via College of Osteopathic Medicine in Auburn. She is interested in surgery and pediatric emergency medicine and hopes to leave all her patients happy, healthy, and laughing. When not studying, she spends time with her cat, Angie, and takes field trips to any coffee shop she can find. She loves anatomy, and she hopes to help you love it too. So with that, I will give the floor to you, Marla.
All right, thank you. So I am Marla Jo, and I'm going to be teaching you about the embryology, because if you weren't wondering by now, where does it all come from? I hope to answer that for you. Wait, can you guys see my screen? Okay, it won't let me change the screen. Oh, there we go. Okay, so first we're going to talk about the lecture objectives. So we're going to explain how the trachea, the bronchial tree, and the lungs are formed. And all of this should be coming from the respiratory diverticulum and the surrounding splanchnic mesoderm. And we're going to go into each of these things. So first, I think a mnemonic is always helpful. So every pulmonologist can see alveoli. I think this is a great mnemonic to learn and to commit to memory. It's going to help you break down each of these stages, both by sort of like a name for what's going on and for like a weekly category. So you know kind of like what the timeline is. And for each stage that we go through, we'll talk about the weeks and then what is going on. And hopefully it'll put all of this into perspective. But we're going to start with the embryonic stage, and that'll last the first 7 weeks of development. And then we'll go into the pseudoglandular stage, which lasts until about week 16. And then the canalicular stage goes to about week 26. The saccular stage is until week 36. And then the interesting one here is the alveolar stage. As you can see, it goes to about 8 years of development, which I think is really interesting. Usually when we think about like embryological development and development of a baby, we don't think about it continuing until we are like a child. So that's really interesting. So starting with a more in-depth overview of the timeline. So embryonically, we have weeks 4 through 6. And you're going to see that all of this sort of makes a almost like a tree-like development where you start with one structure and it just keeps breaking and budding into these different pieces. But you'll have the lung buds, which will go into the bronchial buds, and then the primary bronchi at the end of the 6th to 7th week. And then you'll see the pseudoglandular stage where you'll start to see these further branching into primary, then secondary and tertiary bronchi, and then into the respiratory bronchioles. And these will play into a little bit of what Emmeline was talking about and Adam was talking about with the anatomy and the histology, where you're seeing these breaking more into a conducting and then a respiratory system. So they get a little more specialized as they go. You see at the canalicular stage, at the end of the respiratory bronchioles, you get tertiary and then the alveoli. And then saccular lasts until about birth, where you see vasculature, the surfactant that Emmeline was talking about, and other things that will help mature these lungs to something we can work with when we're born. And then the alveolar lasts beyond birth until about 8 years of age, where you see the multiplication of alveoli to better support an adult pair of lungs. But first, we have to start somewhere, so we're going to start with pleural development. And this happens right around week 3. And we're going to see that the mesodermal tissue, which I believe is this pink stuff in this graphic, where the developing trachea and the lung buds begin to sort of push out into it, kind of like if you would take your hand and push your fist into the other one like this. And it's just going to keep pushing and pillowing out until it makes both a parietal pleural, which will be against the body wall, and then a visceral pleural, which will stay snug up against these pair of lungs that we're developing. And this comes from the mesoderm, which also will help with other system coverings like you may have talked about in the past, like the pericardium and the peritoneum. And again, we have the visceral layer, which is staying up against the smooth organ, and then the parietal, which is going out towards the body wall. So then we have the first real stage of development past the pleural, which is the embryonic stage. Most of the excitement happens from about weeks 4 to week 7. And so you see that the lung buds from the foregut endoderm, which is the lining of the gut tube, will grow and elongate into forming these several structures. So you can see here that this is the pharynx, like Adam was talking about. And then you have it comes off the anterior portion of it to make the laryngeotracheal tube. And then that will go into, and you'll start seeing, this is what I was talking about with the branching tree-like pattern. So you're going to have the tracheal buds come off. And then as you're following it through this graphic, you see that it just keeps making more roots. So you'll have tracheal buds, and then the trachea will start giving off the bronchi. So you'll see bronchial buds forming here. And then that puts us at the end of 4 weeks. So we keep going into the 5th week, and you see buds coming off each one of these. And then the trachea will bifurcate further. You keep getting more and more buds. And you're going to be seeing like primary, secondary, and tertiary that will become more formed as you go on. So at the end of 8 weeks, you have a very, very primitive little lung here with some lobes, some parietal tissue out here that would be on this side. And then on this side, you would have the visceral pleura. So that sort of gives you a good view of the first 8 weeks of development. And then we'll keep plowing through the 7th and 16th. So you have the pseudoglandular stage. So you start seeing here that the bronchial buds are going to get a little more advanced. And I think this is good for, again, so showing that tree root like formation where it just keeps sort of multiplying off of each other. You had these two form, and then off of these two more form. And I think that is a really good way to sort of imagine the lungs developing in your head when you're reading through these slides. Because you're going to see the bronchi and you get up to tertiary bronchi here when it comes a bronchiole. And up until the terminal bronchioles at the end of week 16, this is making up most of your conducting airway. So these first 16 weeks are all about getting the airway to move the air before we turn into the more respiratory down here, which is going to be doing the gas exchange that they were talking about. So at week 16, you have formed bronchi expanding and growing wider in diameter. But then at week 16, you see terminal bronchioles forming down here. And all of this is making up the conducting system. And this is going to be one of the most primitive structures in the embryological body. So you wouldn't be able to survive at week 16, but more maturation will come, and then you'll start seeing a pair of lungs that you could survive with if you were born early. So the canalicular stage, this is from week 16 to 24. So after the respiratory bronchioles have formed, you start seeing more of the vasculature and the alveolar structures beginning to form. So capillaries are going to develop. These little red dots are the capillaries forming around the developing airway. So with that, you're going to start seeing around weeks 19, the specialized cells that Emmeline was talking about, the type 1 and type 2 pneumocytes. And this sentence probably isn't very clear, but the type 2 pneumocytes are the ones making the lung surfactant. Like she said, so they would be sort of, I think you can see them really well here. And then this would be like a vessel, like Dr. Peterson was talking about, that is developing right there to allow for oxygen and carbon dioxide exchange. So once the fetus is born, you would see more of the gas exchange across this, but at this stage, it's going to be more for just helping with the breathing, movement, and the process of getting things through there, because they should all be filled with fluid at this point in development. So these are very primitive alveoli, so we're not just going to go here and in, we're going to keep making them out as we develop further. And it's important to note that all of this is coming from the mesenchymal mesoderm to help see the blood vessels forming, and the capillary bloods are just right here, right here. So then saccular stage, this is about week 24 to birth. So you see a big increase in the number of capillaries as they are getting larger and more, if they're multiplying, then you're going to need more and more capillaries to provide fetal blood flow and then adult blood flow. So a respiratory membrane is an important concept to pause and talk about here. This is going to be made by the type 1 pneumocytes as well as the capillaries of the alveoli that we just looked at. And this is making up that interface that Dr. Peterson and Emmeline were talking about, where the oxygen can be exchanged for carbon dioxide. And as the red blood cells pass one by one through the capillaries, they will shoot off that carbon dioxide to be exhaled out of the body, and then they'll pick up a new oxygen and then leave there, going back into the blood flow to the heart and then the other fetal tissues. So around week 28 to 35, you start seeing the secretion of surfactant, and then this thinning of the epithelial membrane here. And all this is sort of happening one after the other, but also at the same time. So the surfactant secretion and the thinning of the membrane are happening. And this is probably the earliest stage that you could survive prematurely, with a lot of help, of course, but you would be able to take the fetal breathing motion and then also have the surfactant to increase surface tension or decrease surface tension to help keep air in the lung. So you would have an increased chance of survival if born preterm here. And then the maturation that I was talking about at the beginning of this is going to occur for years to come, up until around the age of 8 years. So here, I thought this was a good graphic to put it all together. This is at the saccular stage of development. So you see this early branching pattern with the cells here. And then I believe these are some red blood cells and capillaries packed in here. And then I also thought this was a really good graphic. So this is yes, it is a rat lung development, but it is showing exactly how, as you progress through the days post-delivery, you just keep developing all these little things. They become more numerous. And if that's on a rat, imagining a small human being there would be even more than this in the lung. So this is the only stage, like I said, the alveolar stage of development will occur even after the birth of the child, and it will last until 8 years. And as you can see here, the maturation and multiplication will keep persisting to accommodate increasing oxygen demand throughout your childhood development. So putting it all together, you have the trachea right here. It would shoot off these primary bronchi and then give off secondary and tertiary until you get down to the bronchioles. First the conducting and then the respiratory coming later. So then they're giving off these and they're progressively getting more, I like to call them bubbly because they're turning into acines or the alveoli the further lower you go. So by the time we get down here at around 36 weeks to here, it says 21 years. I'm not the one to ask if it lasts that long. But until some period in the future when you're becoming a older child or young adult, you're going to stop here with all of these alveoli that will hopefully keep you breathing through adulthood. And then you have the alveolar capillaries, and those are developing at the same stage of alveoli. And then here's another good graphic for it, showing the embryological period and then the fetal period, and showing that this just says from 36 weeks. We don't quite know how long it goes. My guess is 8 years. And then just showing that you will develop the conducting zones prior to the transitional and the respiratory zones. So getting the movement of the air comes way before you're actually able to support the oxygen movement across the membranes and conducting it in and out to exchange for gas and nutrients. All right, and I just put another one here for your learning. So you have the airways developing through these stages, and then the vasculature, while I do believe that's a bit advanced at this stage, just knowing that an easier way to look at it is it becomes more numerous the further you go through development, because the more tissue you have, the more blood supply you need. And then I just thought this was a very interesting cartoon to show it because it shows, I don't know, to me it looks like a tree, like with all of its roots. So the more intense the development becomes, the more you have until you start getting that bubbling or grape-like appearance. All right, and then I just thought it was a perfect time to throw in something about the cardiovascular system that you learned about before. So another big development, since these all are occurring at the same time, is that the ductus arteriosus is going to be constricting right at birth. So you'll have a complete set of fetal lungs, and so you wouldn't need all of these bypasses anymore. So your ductus arteriosus would sort of pinch and close. And then the foramen or valley would do much the same thing, where it kind of separates, and then your venous blood supply and your arterial blood supply are going to be completely separate because you no longer need a sort of bypass system to go to the lung. And then down here you can see as well that the inferior vena cava is only going to be carrying deoxygenated blood rather than it being mixed and going back and forth here. And then the ductus venosus does the same thing as the ductus arteriosus, where it will close off and degenerate. And then interestingly enough, you get a fetal remnant that stays behind as the ligamentum venosum, and then these umbilical ligaments, which sort of are just these umbilical arteries that have closed off. All right, so does anybody have any questions for me?
Great job, Marla. I just got really curious while you were talking because I hadn't heard about the 21 years. So I just looked up a quick article while you were talking about that. It's so interesting. It seems like most of it, from where I was just reading one, is that the largest study found that most of it's done by 3 years, but can continue on, for much longer periods of time. That's quite interesting. I bet there's a lot more work that needs to be done there research-wise.
Yeah, I read an article that it was 3 years, and then I read multiple that were 8 years, and I was like, I'm just gonna land on 8 years and see what happens. But then the
Yeah.
21 years, it would make sense if it just kept going. I mean, the larger you get, the more you need.
Yeah. All right, anyone have any questions or for any of our presenters with med school or some embryology?
Marla, before you sign off, maybe just reminding, especially for those high school students that may be viewing this without, in real time, just remind everybody about the significance of mesoderm or mesenchymal mesoderm and why that's so important here. And I can help you a little bit, Dr. Proskura, Dr. Frank, and I will help you, but I think that would be maybe important for everyone to realize. And if you can go back to that slide where you were kind of talking about that, I think that too would be helpful.
Okay. I gotta find it real quick. There it is. So the mesenchymal mesoderm, so mesoderm makes a lot of your connective tissues and sort of like, I just think of it as the one that creates a lot of the vasculature and supporting tissues. You can't have you can't have anything else without having that. It's very crucial to blood supply, which is why I included it here. So as you can see, the mesenchyme is all of this supporting tissue between like all of the airways and the sort of barrier, the epithelial tissue. So you see the capillaries are mainly developing within this. And of course, Dr. Proskura, Dr. Peterson can probably help out with my explanation more. But I would think the big crucial thing here is that it is the blood supply, all the supporting cells, things contributing to the nutrients and the like, I guess, maintenance of the tissues, keeping them going.
That's perfect. And maybe the only other thing is just so that we differentiate, I think in maybe your first slide or when you were talking about the development of the pleura, again, that's connective tissue, but it has to be vascularized as well. So the mesoderm has a role to play in that. And then maybe last thing we should leave them with is the understanding what splanchnic or visceral mesoderm is compared to something that we would call parietal.
Okay, so splanchnic, visceral, and parietal. So the splanchnic is going to be the part of the mesoderm. From my understanding, it was more towards the body wall and more towards the outer tissues, and then parietal and visceral are more towards the organ itself, but visceral is going to be very, very close to the organ, kind of like a second skin. And then the parietal is going to be more towards, it's out here, but it's on the body wall, but it's not on the body wall. That's a very weak explanation.
And maybe I'll just jump in really quickly. So mesoderm has those same kind of designations. So you can have visceral mesoderm, sometimes called splanchnic mesoderm, and then parietal mesoderm. And again, mesoderm does a lot of things, but connective tissue around organs, blood vessels around organs, typically develops from the splanchnic or visceral mesoderm, and then the parietal mesoderm usually gives rise to blood vessels and musculature of the body wall. So I think you did a really good job of explaining that. So thank you.
Thank you. Any questions?
I think you did such a good job that everyone's speechless.
I think that's got to be the explanation. That was so good.
That's what I'm going with. Okay,
All right.
I don't see any, so Dr. Proskura, I'm going to hand it back to you. Excellent job with all three presenters this evening.
Yeah, absolutely. Dr. Peterson, anything from you as far as any updates you wanted to share? I didn't really have much since we all got to hang out last week, which is so awesome.
Right. So I just maybe remind them when the next tutoring session will be, which will be in the new year.
Yeah, in the year of the first Anato-Bee competition. So we are so excited to see all of you in the new year. So we're going to be learning about everything GI. I believe it's 2 weeks into January. So we'll be seeing you then, and you'll get all your invites there the same. So thank you everybody for being here and partaking, and we're just really looking forward to all the future stuff. Thank you again to all of our presenters for all their awesome work, and to Dr. Peterson and Dr. Frank for helping out as well with all of our moderating and answering questions. So thank you everyone, and have an amazing holiday with your families and your friends.
Yep,
Happy
happy holidays.
holidays.
Bye everyone.
Bye.